Welcome to ultrasound imaging for lower extremity deep vein thrombosis. My name is Michael Ross, and I will be taking you through this content. Prior to moving forward, please take a moment and review the learning objectives for this lecture. Deep vein thrombosis is the formation of a blood clot in a deep vein, most commonly in the lower extremity veins, such as the popliteal, femoral, or iliac veins. The clot can partially or completely obstruct venous blood flow, causing symptoms like pain, swelling, warmth, and redness. It is clinically important because the clot can break loose and travel to the lungs, leading to a pulmonary embolism, which can be life-threatening. DVT has an estimated incidence of approximately 67 cases per 100,000 people per year in the general population. It most commonly affects the lower extremities and typically presents unilaterally. DVT is clinically important because it can lead to several serious complications, including post-thrombotic syndrome, pulmonary embolism, and in severe cases, death. Because of these potential consequences, early recognition and diagnosis are critical. DVT is clinically important because early diagnosis and treatment are critical to prevent serious complications, such as pulmonary embolism, while also helping avoid unnecessary anticoagulation when a clot is not present. Common signs and symptoms include acute leg pain, swelling, erythema, and warmth in the affected limb. Several risk factors increase the likelihood of developing DVT, including a previous history of DVT, older age, particularly over 60 years, obesity, prolonged immobility such as bed rest, and medical conditions such as heart failure. These factors may contribute to venous stasis or altered blood coagulation, increasing the risk of clot formation. Accurate diagnosis of DVT is critical. A false positive can lead to unnecessary anticoagulation and increased bleeding risk, while a false negative may allow the clot to progress and potentially cause a pulmonary embolism. Therefore, diagnostic tests with high sensitivity and specificity are essential for correctly confirming or ruling out DVT. Two common diagnostic tests used to evaluate DVT are the D-dimer blood test and compression ultrasound. D-dimer blood test measures fibrin degradation products in the blood. It is highly sensitive but has low specificity, meaning it is useful for ruling out DVT when negative, but elevated levels can also occur with inflammation, cancer, or other illnesses, limiting its specificity when positive. The primary imaging test for DVT is compression ultrasound. In a normal vein, the vessel should collapse with probe pressure, indicating it is compressible. However, when a thrombus is present, the vein will not compress, which helps confirm the presence of a clot. Ultrasound is often combined with color Doppler to evaluate blood flow within the vein. The Wells criteria is a clinical prediction rule used to estimate a patient's probability of having a DVT before ordering imaging. Points are assigned based on clinical findings and risk factors, including active cancer, recent immobilization or surgery, localized tenderness along the deep venous system, leg swelling, and pitting edema. Importantly, the model also subtracts points if an alternate diagnosis is at least as likely as DVT, such as cellulitis, a calf strain, or postoperative swelling. The total score categorizes patients into low, moderate, or high probability of DVT, which helps guide clinical decision-making. For example, low probability patients who have a score of 0 or less may undergo D-dimer lab testing, while moderate or high probability patients typically proceed to compression ultrasound for definitive evaluation. Moderate probability is a score of 1 to 2, and high probability is a score of 3 or higher. This slide shows the clinical algorithm used to diagnose DVT, which combines the Wells criteria with diagnostic testing. First, the Wells score is used to estimate the patient's pretest probability, categorized as low, moderate, or high risk. For patients with low probability, a D-dimer lab test is typically performed first, and if it is negative, DVT can usually be ruled out. For patients with moderate or high probability, the next step is typically compression ultrasound, which is the primary imaging test for detecting a thrombus. If results are unclear or negative, but suspicion remains high, repeat ultrasound may be performed about 1 week later. This stepwise approach helps clinicians efficiently rule out DVT, avoid unnecessary anticoagulation, and ensure that patients with true clots are identified and treated promptly. Let's review a patient case and use the Wells criteria to estimate their pretest probability of DVT and determine whether further testing, such as a D-dimer lab test or ultrasound, is warranted. This case involves a 75-year-old woman who is 4 weeks status post a right total hip replacement and is being seen for the first follow-up visit after hospital discharge. She did receive anticoagulation while hospitalized, and she is currently ambulating short distances with a walker. She reports mild swelling in the calf and thigh that has been present since surgery, along with mild calf and thigh pain. On examination, however, there is no posterior calf tenderness and no pitting edema, and she has no history of DVT or cardiopulmonary disease. Prior to moving forward, use the Wells criteria to estimate her pretest probability of DVT and determine whether further testing, such as a D-dimer lab test or ultrasound, is warranted. In this case, the Wells score is calculated as 0. The patient receives 1 point for recent major surgery and 1 point for entire lower extremity swelling. But 2 points are subtracted because an alternate diagnosis, post-surgical pain and swelling, is at least as likely as DVT. A score of 0 indicates a low pretest probability of DVT, and according to the diagnostic algorithm, the next appropriate step would be D-dimer lab testing to help rule out the presence of a blood clot. Let's review another patient case and use the Wells criteria to estimate their pretest probability of DVT and determine whether further testing, such as a D-dimer or ultrasound, is warranted. This case involves a 52-year-old woman with a 1-week history of right calf pain. 2 months earlier, she underwent an L5 discectomy, and although she recovered well and was walking within a few days of surgery, she did not receive anticoagulation therapy following the procedure. Recently, she noticed that her right calf pain feels different from the leg pain associated with her previous back condition. She has also been increasing her walking distance, and she does not recall any specific injury to the calf. On examination, the right lower extremity shows mild swelling with pitting edema in the calf and localized tenderness. Her Homan sign is negative. She is otherwise healthy and has no prior history of DVT. Prior to moving forward, use the Wells criteria to estimate her pretest probability of DVT and determine whether further testing, such as a D-dimer lab test or ultrasound, is warranted. In this case, the Wells score is 3, with 1 point each for pitting edema, lower extremity swelling, and calf tenderness. A score of 3 places the patient in the high pretest probability category for DVT. According to the diagnostic algorithm, the next appropriate step is compression ultrasound imaging to evaluate for the presence of a thrombus. In this case, the Homan sign was negative. Please note that Homan sign is no longer considered a reliable diagnostic tool because of low diagnostic accuracy. This table demonstrates how the probability of DVT increases across Wells clinical probability categories. In the low probability group, only 5.6% of patients were ultimately diagnosed with DVT or pulmonary embolism. In the moderate probability group, the prevalence increased to 14.1%, and in the high probability group, nearly half of patients, 47.4%, were found to have DVT or a pulmonary embolism. These findings support the clinical usefulness of the Wells criteria for risk stratification, helping guide appropriate diagnostic testing and management decisions. On the last slide, we discussed how the findings in this table from a study from Ridley and colleagues support the usefulness of the Wells criteria for risk stratification, helping guide appropriate diagnostic testing and management decisions. It is also important to note that the vast majority of patients described in this study that went on to diagnostic testing did not have a DVT. I believe this speaks to the importance of the alternate diagnosis, such as postoperative pain and swelling in some cases, causing symptoms that could mimic a DVT. While it is important that the signs and symptoms of the alternate diagnosis are adequately addressed, patients should also be instructed to report to the emergency department immediately if they experience symptoms such as syncope, shortness of breath, chest pain, palpitations, and either new or worsening leg symptoms. As previously noted, if ultrasound results are unclear or negative, but suspicion remains high for a DVT, repeat ultrasound may be performed. We've spoken a fair amount about compression ultrasound, and this figure demonstrates how compression ultrasound is used to evaluate for DVT by assessing whether the vein collapses under probe pressure. In panel A on top, a normal vein fully compresses when pressure is applied with the ultrasound probe, indicating that no thrombus is present. In panel B in the middle, the vein partially compresses, suggesting the presence of a non-occlusive thrombus within the lumen. In panel C, the vein does not compress at all, which is consistent with a completely occlusive thrombus. Therefore, the inability of a vein to fully compress during ultrasound examination is a key diagnostic sign of DVT. Please note that the arteries will remain patent with light to moderate compression. This slide demonstrates compression ultrasound imaging of the common femoral vein, which is a key location evaluated when screening for DVT. In image A, the vein is shown without compression, where the common femoral vein and surrounding arteries are visible. In image B, pressure is applied with the ultrasound probe. In a normal vein, the lumen completely collapses under compression, as seen by the white arrow, which confirms that no thrombus is present. If the vein fails to compress, this raises concern for DVT. The arteries will remain patent with light to moderate compression. The diagram on the right highlights the anatomy of the deep venous system of the lower extremity, including the common femoral vein, which is evaluated in these images and highlighted by the red arrow. The patient and clinician position during this examination is seen in the bottom right-hand corner of image B. This slide further illustrates the principle of compression ultrasound used to diagnose DVT. On the left, the schematic shows how downward pressure from the ultrasound probe compresses a normal vein, causing it to collapse completely. If a thrombus is present within the vein fails to compress, which is a key diagnostic sign of DVT. On the right, the ultrasound images demonstrate this concept clinically. In the normal femoral vein, the vein collapses fully with compression, as seen in image B. The artery will remain patent, even with light to moderate compression. However, in the case of acute DVT, the vein remains open and non-compressible as seen in image D, indicating the presence of thrombus within the vessel. Thus, loss of normal venous compressibility is the primary ultrasound finding used to diagnose DVT. This slide demonstrates the role of Doppler ultrasound in the diagnosis of DVT by evaluating blood flow within the venous system. In image A, color Doppler shows normal venous blood flow at the junction of the greater saphenous vein and the common femoral vein. The presence of a normal blue color flow and Doppler waveform indicates that blood is moving freely through the veins. In image B, Doppler ultrasound shows a thrombosed greater saphenous vein, where there is absent flow within the vein, as we see no color within the vessel. This reduced flow pattern suggests venous obstruction caused by thrombus. The diagram on the far right highlights the anatomy of the deep venous system, including the junction of the greater saphenous vein and the common femoral vein, which is highlighted by the purple arrow and was evaluated in image A, and the greater saphenous vein, which is highlighted by the red arrow and was evaluated in image B. Together, compression ultrasound and Doppler imaging provide complementary information, assessing both vein compressibility and venous blood flow to help confirm the diagnosis of a DVT. Patient and clinician positioning for this examination are seen in the image in the bottom right-hand corner of image B. This slide highlights the role of Doppler ultrasound in evaluating venous blood flow when assessing for DVT. In image A, a normal femoral vein is shown with color Doppler, with normal venous blood flow filling the entire lumen, indicating unobstructed venous blood flow. In image B, there is partial venous thrombosis, demonstrated by a focal absence of color flow within part of the vessel as pointed out by the white arrows, which suggests that a thrombus is obstructing normal circulation. The diagram on the far right illustrates the anatomy of the deep venous system of the lower extremity, including the femoral vein as highlighted by the red arrow and evaluated in these images, as well as the common femoral, popliteal, and tibial veins, which are key locations during Doppler ultrasound for suspected DVT. Overall, Doppler ultrasound complements compression ultrasound by allowing clinicians to assess both vessel compressibility and the presence or absence of venous blood flow, improving diagnostic accuracy for DVT. This slide highlights the role of Doppler ultrasound in evaluating venous blood flow when assessing for DVT. In image A, Doppler ultrasound shows an occlusive venous thrombosis, demonstrating complete absence of color flow in the popliteal vein. Patient and clinician positioning for this examination are seen in image B. The diagram on the far right illustrates the anatomy of the deep venous system of the lower extremity, including the popliteal vein, as highlighted by the red arrow and evaluated in these images. In summary, DVT is the formation of a blood clot in the deep veins, most often in the lower extremity, and it's clinically important because of the risk of pulmonary embolism. Patients typically present with unilateral leg pain, swelling, warmth, and redness, though these symptoms can overlap with other conditions. Key risk factors include recent surgery, immobility, prior DVT, age, and medical comorbidities. Clinically, we use the Wells criteria to estimate probability. Low-risk patients can be screened with the D-dimer blood test, while moderate to high-risk patients should undergo ultrasound examination. On imaging, a non-compressible vein confirms DVT, and Doppler may show reduced or absent blood flow. The key takeaway is to combine clinical judgment with appropriate imaging as early diagnosis is essential to prevent serious complications. This concludes ultrasound imaging for lower extremity deep vein thrombosis. Thank you.